Thank you, Mr. Chairperson. Assalamualaikum and very good evening. I would like to present to you my study entitled Understanding the Factors Associated with IADL Disability Among Elderly in Kelantan, Qualitative Findings from a Mixed Method Study. According to WHO, elderly is defined as a person who aged 60 years old and above in developing countries. The proportion of older people is estimated to double from 12% in 2015 to 22% in 2050. By 2030, there will be 5.8 million elderly in Malaysia, making up about 15% of the total population. Aging carries with it a higher disability rate due to the burden of health risks across a lifespan of disease, injury, and chronic illness. Disability is a dynamic interaction between persons with impairments, attitudinal and environmental barriers that hinder their full and effective participation in society. IADL, instrumental activities of daily living, measures more complex activities which may not necessarily be performed daily but allow a person to live independently in their community. IADL refer to tasks requiring maximum cognitive capacity to make mindful decisions. This study used Malay version of the Lawton IADL scale. Disabled IADL is defined as inability to perform one or more of the listed 8 activities in the scale. These are the objectives of the study. Today's presentation will be focusing on the third objective of the study, which is to explain the factors associated with IADL disability among the elderly in Kelantan. This is a mixed method sequential explanatory study which consists of two-phase design. Phase 1 is the quantitative cross-sectional survey and the phase 2 is the qualitative phenomenology study. This study was conducted in Kelantan from January 2020 to August 2021. The study population was elderly attending health clinics in 4 districts in Kelantan. The inclusion criteria was participants of phase 1 who had low IADL scores, and the exclusion criteria are those who has acute medical condition or has been diagnosed with dementia or severe cognitive impairment. This study used purposive sampling method and phenomenology using in-depth interview as the research method. The initial plan for the data collection was face-to-face interviews. However, due to the COVID-19 pandemic and MCO in 2021, it was changed to phone interview. The research tools were phone recorder, field note, and interview guide. Thematic analysis was done by using a 5-step process by Saldana 2015, and the data were analyzed using Microsoft Excel. Initially, there were 30 respondents invited to participate in the phase 2 study. There were those who had low Lawton IADL score less than 6 and consented during phase 1. Pilot study were conducted for 2 respondents, and then the pilot interviews were transcribed and analyzed and main teams identified. The subsequent interview was carried out. The researchers were constantly checking and rechecking for teams in each interview to see if any new teams emerged. Data saturation was reached after interviewing 14 participants, and additional 2 respondents were interviewed to ensure true saturation, making the final sample of 16 participants. Final data analysis was done and discussed among team members until everyone agreed on the final results. 36.3% of the elderly attending health clinics in Kelantan had disabled IADL status, and this table 4 shows logistic regression analysis of associated factors with IADL disability. The significant factors found during phase 1 quantitative study were older age group, unmarried, no formal education, individual monthly income of less than ringgit Malaysia 1,000, and those who reported fair or poor self-rated health status. There are 4 major themes emerged from the qualitative data on factors associated with IADL disability: age-related problems, social support, poor educational attainment, and income. Age-related problems are the most important factors associated with IADL disability among the participants. Older age is associated with various age-related conditions such as accumulation of comorbidities, frailty and fatigue, as well as low motivation. These conditions predispose elderly to be disabled in IADL. Low social support can affect functional disability and increase the sense of loneliness in elderly. When a married couple lost their partner, they may lose of dependency and cannot manage IADL on their own. However, too much family assistance can poorly disadvantage this population as they appear to be less active and lose independence to carry out IADL tasks. The interviews also showed that poor educational attainment influenced IADL disability among elderly. According to respondents, most of them had problems to manage their drugs because of poor literacy. Some of them believed that poor education was a barrier to an effective communication. They often felt incompetent and lack of confidence, thus lead to communication failure. Healthcare resources and need are important to maintain physical functioning and elderly well-being. Low income can affect poor IADL functions by neglecting the needs for healthcare. Now we come to the discussion. Older adults naturally accumulate comorbidities with increased age. The pathophysiology of aging shows there are chronic downregulation of the multiple organ system occur with age, which lead to the functional breakdown and promote development of chronic diseases. The accumulation of comorbidities may eventually cause IADL disability. Frailty and fatigue are also the common age-related problems. Frailty characterized by low physical activity, muscle weakness, and unintentional weight loss. Decline in gait speed and muscle strength can contribute to the physical inactivity and increase risk of IADL disability. Elderly with fatigue have difficulty to consistently execute normal IADL at the same pace. They started to have reduction in activity levels and consequently deteriorate IADL disability. Elderly persons are usually presented with low motivation and low energy. Those with low motivation are more likely to withdraw from their usual IADL tasks because they are no longer interested in them. Death of spouses has left many elderly with loss of dependency. They become ill-prepared to manage IADL tasks, for example, managing the finance, transport, house chores, and after the spouse pass away, there will be change of support system as well. Loss of long-standing dependency can increase the feeling of loneliness and may eventually deteriorate IADL function. However, too much assistance from family members was also not good at all time. It can lead to a sedentary lifestyle because most of daily tasks are executed by their family members. The skills and competence started to wear out and elderly may lose their independence in IADL performance. Poor literacy indicating poor brain organization, linguistic cognitive functions, and weaken the decision-making process. For example, in this study, poor literacy causing poor comprehension of prescription drug labels, elderly appeared to be less confident and require assistance. And at the end, they struggle to manage their own medication, which is their IADL task. Apart from that, poor educational also can cause barrier in communication. Elderly may have difficulty expressing themselves on interpreting the language of communication, thus lead to breakdown in communication. Lack of general skills or specific knowledge that facilitate technology utilization also can cause elderly to be less confident and unmotivated to learn. And in this study, most of them has trouble to use mobile phone and ATM. Low income can lead to lack of access to better health resources. Elderly could not afford technology or services to overcome their disabilities, such as instrumental assistance to maintain IADL functioning. Having sufficient income may improve IADL functions by modifying better living condition. This was the first study, the first mixed method study that explored factors influencing IADL among elderly in Kelantan. It allowed a better evaluation of data and also allow participants to share their experiences. Healthcare access bias may occur as the study sample only involved older people who attended the clinics and miss out those in the community who did not have chance to attend the clinics. During the COVID-19 pandemic, the interviews were conducted through phone calls and there was lack of many nonverbal communication cues. This can lead to risk of misunderstanding and poor communication. As for the conclusion, the participants' report suggests limitations in the IADL function when they bring concrete illustrations of the age-related problems, social support, poor educational attainment, and income. This study findings underline the need to improve strategies in health promotion and prevention, for example, to promote healthy aging at early life course. An equitable universal social protection policy should be made available for all elderly. And the technology intervention should be more simplified for elderly by creating innovation, for example, using photo instructions instead of words, building the friendly user website, using large fonts and big button. This is all our references. And with that, thank you.